Let's get into the eye exam for a little bit. So the first thing we're going to notice is, does the person wear glasses or not? And we're going to ask about this with their health history. Do they wear glasses? Do they wear contacts? How long have they had them? Another important question is, were they prescribed or did they go to the pharmacy and just pick them off a shelf? When did they see their eye doctor last? Also, we're going to want to ask about any changes to their visual status. Are they seeing any halos around things? Do they have dim vision now? Is it harder to read? Are they having pain, redness, swelling, any cross-eyed? Are they seeing double? These are all things that could lead a patient to come in for problems with their eyes. Now let's take a look at the external anatomy that we'll use for inspection. First, we're going to notice the sclera. This is the tough protective white coating. It should be smooth and transparent. We'll notice the iris. This functions as a diaphragm, varying the opening to the pupil, allowing more or less light in. This is the colored part of the eye. Continuing to look at the external anatomy, we notice the upper and lower eyelids and that there's no lid lag, that there's strong muscles. We also take note of the canthus. This should be pink and moist. This is where eye drops would be placed if a patient needed it, at the medial canthus. Preliminary inspections of the general eye anatomy is going to include their eyebrows, looking for hair distribution, that they're even. Also their eyes. Are they evenly set? Is one drooping more than the other? The other thing to the eyes alignment is, how do they align with the ears? People with Down syndrome often have ears that are downset compared to their eyes. We want to make sure that we're looking at their pupils in natural light. What size are their pupils? Are they even? Many of you during our lab checkoff day noticed the mannequin had unequal pupils. That's a sign because he's had a stroke. Other brain injuries can cause this as well. We had to check the eyelids. We're checking the eyelids for lid lag. This is a static situation, and when the upper eyelid is higher than normal when somebody stares down. It can be a sign of thyroid disease, or it could be related to fibrous changes related to their eyelid or congenital ptosis. Ptosis is that known as lazy eye. This is when somebody's eyelid is drooping or falling below. It can be worse when they're awake for longer periods and they're tired. This is also the time when we need to examine the conjunctiva and the sclera. The conjunctiva should be pink and moist, and the sclera should be clear white. We can also notice if there's any nystagmus at this time. Does their eye twitch uncontrollably? That's a nystagma. Next, we will consider the extraocular muscles and their functions as they relate to the cranial nerves. Cranial nerve number 4 is the trochlear nerve, which innervates the superior oblique muscle. This one is going to be responsible for having the eyes go inward towards the nose or cross-eyed. Cranial nerve 6 is the abducens nerve, and it innervates the lateral rectus muscle, which abducts the eye or moves the eyes to the outer position. Cranial nerve 3 is responsible for everything else. It innervates the superior, inferior, and medial rectus and inferior oblique muscles, allowing the eye to look up laterally, medially, down laterally, and down medially. Now let's look at the Snellen eye chart testing cranial nerve number 2.
This is Sarah with RegisteredNurseRN.com, and in this video I'm going to show you how to assess visual acuity using a Snellen chart. Whenever you do this, you are assessing cranial nerve 2, which is the optic nerve. And of course, whenever you perform this skill, you will need a Snellen chart. Now we're going to test visual acuity using a Snellen chart. And what you're going to do is you're going to have your patient stand about 20 feet from the chart. So Ben, if you'll stand about right there for me, and ask your patient, do you wear glasses?
No.
Okay, and if your patient does wear glasses, you'll want them to wear those for this test. Okay, so what we're going to do, look at that chart over there and try to read the lowest line for me that you can read, okay? And first we're going to cover your right eye, then your left eye, and then we'll do both eyes, okay? So cover your right eye. Okay, and what line can you read?
8.
Okay, read it for me.
D, E, F, P, O, T, E, C.
Okay, very good. Okay, now we're going to cover up your left eye and do the same thing. And again, whatever line you can read, let me know.
8.
8 again, okay.
D, E, F, P, O, T, E, C.
Okay, and now read with both eyes. And what line?
8.
Okay.
D, E, F, P, O, T, E, C.
Okay, and he read from line 8, so that means that he has 20/20 vision. And this means that he can see the same line of letters at 20 feet that a person with normal vision can see at 20 feet. However, let's say that in his left eye, he could only read like line 6, which is 20/30. That would mean that his left eye sees at 20 feet that a person with normal vision would see at 30. Okay, so that is how you assess visual acuity using a Snellen chart.
Next, we'll use our pen light. We're going to check to see if the pupils are equal, round, reactive to light, and accommodation. We do this by bringing our pen light into the field of vision in a dim room. The pupil should get smaller or constrict as the light comes into field. To check accommodation, we have the patient focus on our pen light and see that both eyes are able to focus on it. Next, we'll look at how to use the ophthalmoscope.
Hi, my name is Tanya Padilla-Kandi. I'm a fourth-year medical student, and today we'll be going over how to use the direct ophthalmoscope. The key learning objectives for this video are to understand the utility of the direct ophthalmoscope, to identify key anatomical structures visible with a direct ophthalmoscope, to learn the parts and settings of the direct ophthalmoscope, and to learn the exam technique of the direct ophthalmoscope. The direct ophthalmoscope allows you to look at the health of the retina, including the optic nerve, the veins and arteries, the macula, and the fovea. It produces an upright image of about 15 times magnification. In order to use the direct ophthalmoscope correctly, it's important to know the different parts and settings of the instrument. Let's begin by looking at the practitioner side. This is the side that will be facing your eyes. The first thing you're going to want to do is turn on the instrument. In order to do this, you'll need to depress down on the green button and turn. This is called the rheostat, and it controls the brightness of your light. This is the eyebrow rest. This is the viewing window. This is the diopter dial. And this is the diopter display. The far-sighted eye requires more green numbers, and the nearsighted eye requires more red numbers. If you do not wear glasses or contact lenses, set the diopter to 0. If you do wear glasses or contact lenses, you can adjust it by looking at an image about 10 feet away, adjusting the dial until the image comes into focus. The patient side includes the viewing window, the filter switch. This switch allows you to change the color of the light. The red-free light allows you to look more closely at the vasculature. The aperture switch allows you to change the size of the light. The small aperture allows you to look at a constricted pupil in a well-lit room. The blue light allows you to look at corneal abrasions or ulcers with the use of fluorescein dye. The slit allows you to look at contour abnormalities. The grid allows you to measure distances between lesions. The large light allows you to look at a dilated pupil after using mydrotic drops. And the median light allows you to look at an undilated pupil in a dark room. Now that you know the different parts and settings of the direct ophthalmoscope, we can learn the exam technique. The first thing you need to do is wash your hands and introduce yourself to the patient. We will be examining Kevin today. And the most important part of this exam is to position the patient correctly. You're going to want to have the patient's eyes at the level of the instrument. So we'll be moving you up, Kevin. All right, so now that he's in the correct position, we can begin the exam. The reason why the position is so important is because it's going to allow you to visualize the optic disc more easily. Some textbooks do say you can go in and follow the vessels until you reach the optic nerve. However, positioning the patient is the easiest way to do it. So now that he's in the correct position, Kevin, I'm going to ask you to look at an object on the wall directly ahead. And then you'll want to turn the instrument on. And at this point, you'd want to dim the lights so that you could get a better view. However, for this video, we will be leaving the lights on. So since we're in a well-lit room and his pupils are constricted, I'm going to start with the small aperture. And now you're going to want to place your hand on the patient's head and your thumb on the patient's eyebrow. Placing your thumb on the patient's eyebrow allows you to get as close as possible without running into the patient's eye. We're examining his left eye, so we're wanting to use our left hand and our left eye to examine the patient's left eye. So you want to start at about 6 inches from the patient's eye and then about 15 degrees from the center. Now that you're in position, look for the red reflex. Get closer until you have the optic nerve in sight. You can change the diopter settings to focus on the optic nerve. Once you see the optic nerve, look at the cup to disc ratio. You can move slightly up or down to look at the vessels. Move temporally to look at the macula and the fovea. Now you can repeat the same technique on the other eye. Thank you for watching this educational video. Please join us at the following Moran Core website for more information on basic eye exam techniques and other ophthalmology topics.
In this section, we inspected and assessed the eye. We asked health history questions regarding glasses. We assessed the position and alignment of the eyes, inspected the conjunctiva and the eyelids. We looked at perla with our pen light, measured the size of the pupil before we did that. Using the ophthalmoscope, we visualized the ocular fundus, used a Snellen chart to demonstrate cranial nerve 2, and we asked about nystagmus and assessed for ptosis. Doing all these criteria gives us 3 points in this section.